Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an unconditional independent educational grant from Chiese Farmaceutici Society per Regione.
This program is presented by Medscape Education Global.
Ladies and gentlemen, welcome. My name is Leonardo Fabri. I am an eminent scholar of internal and respiratory medicine at the University of Ferrara, Italy. Welcome to this program entitled Coexisting Comorbidities, Advancing Holistic Care in COPD. Now, the concept is the following. Until 50 years ago, the focus was on COPD on the left as a single disease of the lung. Then about 15, 20 years ago, Gold introduced the concept of COPD and comorbidities, suggesting that there were concomitant chronic diseases that could contribute, that could be caused by spillover of mediator from the lung and were concomitant and could aggravate the patient. Now, the concept we are working on today and we have developed is that we are moving out of a single disease approach because the overlap of the different group of diseases that I will describe makes them different when they are combined, as shown on the panel on the right. Here, the authors of the paper selected 18 diseases in cluster: mental cluster, the cardiovascular, respiratory cluster, metabolic cluster, and multiple organ loss of tissue cluster. Grouping was done to group the diagnostic approach to each of them, assessment of severity and management. Now, as shown in these slides, for each of the cluster, there is a group of exams that are finalized to classify the patient at the beginning, at the first encounter, as a multimorbid, considering that there is no single disease in this concept. And specifically, COPD by itself does not exist. It is invariably associated with other clusters, other diseases that are reported in the quadrant here. And in the second part of the slides, we suggest which test should be repeated in these patients, because the concomitant chronic diseases may develop over time before and after the COPDs as developed and clinically relevant. Unfortunately, these concomitant diseases are often underdiagnosed or misdiagnosed. This is a classic study where two authors were comparing the prevalence of the single chronic diseases with COPD in orange when searched and in blue when detected by looking at medical record. And as you can see, the active search was actually superior to the recording in detecting and helped in making the diagnosis of these concomitant diseases. Now, this is a recommendation to actively search for these diseases. Now, the coexisting doesn't mean cause-effect. The term comprised COPD and other diseases, in our case is type 2 diabetes or cardiovascular disease, refer to the co-occurrence and interaction of two or more of these diseases who share common risk factors and pathobiological, physiological mechanism. These syndemics brings to a negative synergistic effect between these two diseases or two or more diseases. They interact negatively, worsening the prognosis. The typical prototype, the most frequent and relevant, are probably the COPD and cardiovascular diseases, or the type 2 diabetes and COPD and cardiovascular diseases. See, both COPD and diabetes increase the risk of cardiovascular diseases. So there is an amplification in this respect. Now, this complexity is not only limited to the phase of stable condition, but also during the exacerbation. And in fact, the exacerbation here classified according to the point of care that need always to be carefully diagnosed as being induced by COPD exacerbation or by other confounders or mimicker. And these here are the diseases that more frequently can worsen or mimic the exacerbation of COPD characterized by dyspnea. And with this approach, you have a treatment for only COPD if you don't have the other diseases, and you have to take care also of the other when they are present, whether they are the cause or where they are combined. For this reason, we suggest to have a particular attention, in addition to the yearly or 3-yearly regular review of the patient, to look at the patient when it worsens and at home or in the clinic outside the hospital, or when he's admitted, with more aggressive diagnostic approach. So in conclusion, a person-centered clinical approach, as described, should be taken in addressing the multimorbid patient with COPD, taking into account of the several comorbidities. So you should take care, either by yourself or with the consultant, of the concomitant diseases in chronic condition, stable condition, and also during exacerbation. And as I mentioned, COPD and most chronic diseases are not just comorbidities, but they are syndemic. So they are coexistent, worsen the prognosis of each other. Most chronic are increased in patients with COPD and vice versa, but unfortunately, they are often underdiagnosed and should be selected. Exacerbation are complex and may be due to the combination of these different diseases. Patients with multimorbid should be considered at high risk of concomitant diseases, and so they should not only approach and treat it both for COPD and concomitant chronic diseases, but also for their risk factor. Thank you for watching. In the next chapter, Dr. Cruz will discuss more about the impact of exacerbations on patients with multimorbid COPD.
Hello, I am Álvaro Cruz, Professor of Medicine at the Federal University of Bahia in Salvador, Brazil. I'm also the President of ProAR Foundation. In this chapter, I will discuss the impact of exacerbations on patients with COPD, a disaster. Exacerbations of COPD are defined by increased dyspnea and or cough within 14 days, often accompanied by tachycardia and or tachypnea. They are characterized by increased airway and systemic inflammation, often caused by infection, pollution, and other insults to the airways. Look at this. In-hospital mortality of COPD compared to acute myocardial infarction in Brazil over the years. While the cardiac disease is declining in terms of in-hospital mortality, it doesn't happen to COPD. over 10% of patients admitted with COPD, they die. And worse, in 4 years, over half of patients that had an admission due to COPD are not live. A severe COPD exacerbation can trigger or worsen other existing conditions, increased cardiovascular risk, major increase, accelerated lung function loss with terrible profile of COPD patient, and mental health problems as well. Even a single COPD exacerbation can lead to a significant decline in lung function and an increase in the risk of future exacerbations. COPD exacerbation also impact physical activity, quality of life, and mortality. We have to do something when a patient has an exacerbation because he is running a major risk of several problems. COPD is driven by abnormal airway inflammation, and most exacerbations provoke an additional inflammatory surge. And patients who experience frequent exacerbation present higher levels of inflammation and tend to have recurrent exacerbations. One exacerbation is a major risk factor for another exacerbation. Heart failure, lung cancer, osteoporosis, gastroesophageal reflux disease, diabetes, depression, asthma, among others, correlate with more frequent exacerbation. That is, the comorbidities also increase the risk of exacerbation, as well as the exacerbation increase the risk of worsening the comorbidities. Asthma is particularly linked to severe exacerbations, and bronchiectasis also lead to COPD exacerbations. Well, the Global Initiative for COPD bring a list of discharge criteria and recommendations for follow-up, and I think you should have a look at it. So it suggests a full review of clinical and laboratory data, maintenance therapy, and understanding of the patient for that, reassess inhale technique, ensure understanding of withdrawal of acute medications, steroids, and or antibiotics, assess need for continuing any oxygen therapy, management plan for comorbidities and follow-up, and ensure follow-up arrangements, early follow-up in less than 4 weeks, and a late a little bit before 12 weeks. All clinical and investigation abnormalities have to be identified. Some more recommendations making clear this distinction for a short-term review in 1 to 4 weeks, and then a medium-term review, 12 to 16 weeks, can be seen also in the Global Initiative for COPD report. This is a very important point here, interventions that reduce the frequency of COPD exacerbation, though bronchodilators do it either alone or in combination, usually long-acting bronchodilators, corticosteroids containing regimens of inhaled corticosteroids, so bronchodilators with corticosteroids, other anti-inflammatory non-steroidal medications, but also having vaccines and eventually using macrolides could prevent exacerbation as well, but also other medications and various other, especially smoking cessation, rehabilitation, and other procedures, including lung volume reduction. But what is most important is the evidence supporting a reduction in mortality with pharmacotherapy and non-pharmacotherapy in COPD patients. Initially, this triple therapy combination of two bronchodilators, long-acting LAMA and LABA, and inhaled corticosteroids have been shown in more than one study to provide a reduction in all-cause mortality from 30 to 50%, but also non-pharmacological therapy, smoking cessation, pulmonary rehabilitation, and many others. So we have to do something for these patients. We can save their lives. COPD exacerbation are a major threat. Life, health, and well-being, including lung function and comorbidities, are affected, and recognizing and managing well COPD exacerbations are crucial to minimize risks. Thank you for watching. In the next chapter, Professor Yualin Song will illustrate the treatment approach for a patient with COPD and asthma.
Hello, everyone. I'm Yuanlin Song, a professor of pulmonary medicine at the Zhongshan Hospital, Fudan University. In this chapter, I will discuss a patient case with COPD and asthma. This patient is a 70-year-old male. And the patient is having a recurrent chest tightness and shortness of breath for 40 years. The patients are often triggered by exposure to dust and irritant odors. So 1 month ago, the patient, during the traveling, the patient began to have a fever, experience a recurrent of tightness and shortness of breath, accompanied by a cough and expectoration. So when the patient come to the hospital for further examination, the personal history show smoking for 50 years. The lung oscillation suggests the patient's right lung has mild wheezing during the expiration. Blood test show neutrophil increase, CRP is increased, IgE increased, and EBG shows decreased oxygen pressure. AP aspergillosis fumigatus IgE is 0.58 is increased. The tested CT showing a lower lobe patty infiltration, suggesting the patient may have community acquired pneumonia. So we give the patient a diagnosis of asthma, COPD, community acquired pneumonia, and possibly ABPA. The patient is also having an acute attack of asthma and acute exacerbation of COPD. So we start to treat the patient, giving oxygen inhalation, giving intravenous prednisolone, together with a bronchodilation regimen. The patient is still having symptom continuously, so we changed the treatment options. So eventually the patient get biologics using the dupilumab, and also with the step-down use of steroid till 5 milligram PO. The patient then, the symptom get relieved and discharged from the hospital. So later on the follow-up, the patient lung function suggesting the FEV1 over FVC, so 47%, and the FEV1 prediction is 48.3%. The suggestion that the patient is having irreversible airflow limitation. Plus the patient, smoking for 50 years and with the sputum, with the cough, from the lung function test, the patient is having a COPD. So based on the previous clinical examination, previous PFT report, the current ABG analysis, chest X-ray and CT, the FeNO test, IgE test, plus the sputum bacterial culture, all this suggests the patient is having asthma. The reason is the patient began to have asthma-like symptom, wheezing when he was 30 years old, and the patient is not at a standard therapy for asthma. Also, the patient IgE against aspergillosis is increased, suggesting the patient may have fungus infection in the airways. The patient also have a COPD due to the chronic cough with the sputum, plus PFT test showing a irreversible airflow limitation, FEV1 over FVC less than 70%. From the CT scanning showing a new infiltration in the left lower lobe, suggesting the patient may have a community-acquired pneumonia. So how to triage the patient so we can have early intervention? So clearly, stop smoking, avoid allergy exposure that could prevent the acute exacerbation of COPD. Also, avoid the acute attack of asthma. So regularly, based on the treatment guidelines, the patient need to have ICS and LABA for the asthma. And the patient lung function declined, have a irreversible airflow limitation. The patient FEV1 prediction is less than 50%. So based on the good guidelines, the patient need to have triple therapy. That means ICS, LABA, and LAMA. From the bacterial culture, the patient may have fungus like aspergillosis. Also, bacterial culture states positive for cytomegalovirus. The patient may have in antibiotics. Another very important issue is rehabilitation. So rehabilitation do help the patient recovery from declined lung function. So the reason is due to the crossover of the pathophysiology changes due to the increased airway thickening, the airway remodeling, so that the small airway function declines. That could induce hyperinflation. So hyperinflation could reduce IC, that makes the patient have a symptom of dyspnea. Emphysema suggests the patient may have a reduced diffusion capacity, so we need to give a long-term of the oxygen inhalation. If the hypoxia cannot be relieved, the patient may develop hypoxia-induced pulmonary hypertension. For the asthma, we need to evaluate the eosinophil count from blood, from the sputum. So if patient have increased eosinophil count from sputum, from blood, increased FeNO, and also increased IgE, suggests the patient may have type 2 inflammation. The patient need to have ICS and LABA and possibly biologics if the ICS LABA cannot significantly reduce the patient's symptom. So asthma is a risk for the development of COPD if the asthma cannot be controlled correctly. And asthma and COPD are two separate different diseases. If the patient have concomitant of COPD and asthma, so they should be treated separately based on the guideline. Thank you for your watching. So for the next chapter, Dr. Fabry will illustrate the treatment approach for patient with COPD and diabetes.
Ladies and gentlemen, welcome back. In this chapter, I will illustrate the treatment approach for a patient with COPD and diabetes. The patient profile is very frequent. 20-30% of the patient with COPD in this age range have also diabetes, had COPD for 10 years, and type 2 diabetes in this specific case for 5 years, poorly controlled, other comorbidities, hyperdyslipidemia, and hypertension. Now, this again is an example of syndemic diseases. Systemic inflammation in COPD contributes to insulin resistance by increasing pro-inflammatory cytokine, which impair glucose metabolism and beta cell function. Conversely, hyperglycemia in type 2 diabetes exacerbate oxidative stress, leading to endothelial dysfunction, reduced lung function, and impair pulmonary repair mechanism. The synergism, negative synergism of the two diseases is reported in this slide. Now, the management of this systemic coexistent of COPD and type 2 requires an integrated multidisciplinary approach. There should be a collaboration between the pulmonologist and the endocrinologist. The gold recommendation recommend diabetes in COPD patients to be treated according to the standard diabetes guidelines, while COPD management should follow established respiratory protocols produced by Gold. Screening for metabolic syndrome and diabetes is advised in COPD to improve prognosis and reduce morbidity, addressing shared risk factors, optimizing glycemic control, and providing holistic care, including psychological support and palliative care, are essential for improving quality of life and clinical outcome in these patients. And this will be the summary slide of the type of pharmacological treatment that we use in the two diseases. We highlighted in red those that can cause adverse effect on the other diseases. The systemic beta stimulant, for instance, cause adverse event on diabetes. Similarly, the most popular and most well-known oral corticosteroids actually cause many side effects in patients with this stabilized type 2 diabetes. Other treatments have no effect or beneficial effect. For instance, the most common double or triple therapy put COPD under control and so reduce the need for beta 2 stimulants, either inhaled that are tolerated or systemic. And another drug that is interesting is roflumilast, that is used in the most severe and resistant patient that actually benefit of the PDE4 inhibitor effect on the glucagon pathway and may have some beneficial effect in diabetes. In yellow are the first line two class of drugs that have been recently put at the top of the priorities of diabetes. The glucagon-like peptide 1 receptor antagonist or sodium glucose co-transporter 2 inhibitor, both of them have been shown to have beneficial effect, even if not in prospective specific clinical studies, but just retrospective analysis, both in cardiovascular disease and respiratory diseases, exacerbation. Insulin, which obviously is needed to control glycemia, may have adverse event in COPD. Metmorphin may have some beneficial effect, and the drug that for several reasons, including the potential adverse event on the respiratory, are the sulfonyl ureas or thiazolidinic treatment. This is an example, of the explosion of the interest in this kind of drugs that I mentioned before a few years ago, when it has been discovered that they actually have beneficial effect also on other diseases. And here are two panels that I don't expect you to read the panel, but here you can see what are the treatment algorithm in the pre-diabetes and in the complication of diabetes. Because like COPD, also diabetes is associated with hypertension, cardiovascular, so they give guidelines for that unfortunately are not provided yet on COPD. In conclusion, COPD, diabetes, and cardiovascular diseases, for the reason I mentioned before, are not just comorbidities, but they are syndemic. They are coexisting worse the prognosis of each other. Cardiovascular diseases are increasing patients COPD and diabetes and vice versa, but they are often underdiagnosed. Exacerbation of symptoms in a patient with multimorbid COPD are associated with increased risk, major increased risk of cardiovascular event in the year after the hospitalization. And patients with COPD and diabetes should be considered at high risk of developing cardiovascular disease. So they should not only be treated for COPD and diabetes and diagnosed cardiovascular disease, but also treated for the risk factors for cardiovascular diseases. Thank you for watching. In the next chapter, Professor Jorgen Choblu will illustrate the treatment approach for a patient case with COPD and anxiety and depression.
Hello, I'm Arzu Organcioğlu. I'm a professor at the Department of Pulmonology at Celal Bayar University in Manisa, Turkey. In this chapter, I will discuss a patient case with you with COPD and psychiatric conditions, especially anxiety and depression, which I believe so important. He is a 60-year-old male, a retired engineer, and he had a very active business life and sports as well. He is a heavy smoker and still smoking, and he has COPD for 10 years. His main symptom is breathlessness and dyspnea at exercise, because he still wants to exercise. He cannot walk the distances he used to. FEV1 was 50% predicted. CAT COPD assessment test was 35, which is the highest one is the 40, and MMRC 4, very bad, And he was using and he was treated with a prescription of ICS-LABA high dose and add-on LAMA. So here we are seeing a very severe patient of COPD and described as the highest dose of the treatment. But he's not compliant to the treatment and he denies that he is having COPD and he continues smoking. He wanted to exercise. He wanted to live his life according to his willing. But he has a moderate major depression. He was, of course, being isolated because he cannot move, he cannot exercise. And people started antidepressive treatment and the pulmonary rehabilitation for that. And that will make an impact because we know that if the patient has anxiety and depression, the prognosis is poor. And younger age, female sex, smoking, lower FEV1, cough, higher St. George Respiratory Questionnaire, and cardiovascular comorbidities plays important role. So when depression and anxiety coexist, patients face a heavier dyspnea burden and a worse quality of life and higher stress levels, of course, like a vicious cycle. And living these conditions untreated leads to social isolation, as we see in our patients, increased healthcare utilization, premature mortality, of course, and greater overall disease burden. There is no, according to the GOLD strategy report, there is no evidence that anxiety and depression should be treated differently in COPD patients. We treat it as we do, as usual. Rehabilitation should be stressed. There is the beneficial effects of physical exercise. When your patient starts moving, you gain the patient for the medical management. And it's common with other psychiatric illnesses. And COPD patients, that's an important information and sad information, 1.9 times more likely to commit suicide if we don't treat them. So following COPD diagnosed patients are more likely to develop depression, and the risk is greater in patients with worse breathlessness, as we see in our case. So screening can be done. Patient health questionnaire 2 for depression and generalized anxiety disorder 2 for their anxiety. I strongly recommend you evaluate your patients for anxiety and depression. Pulmonary rehabilitation and cognitive behavioral therapy are effective in elevating anxiety and depressive symptoms. Antidepressant drug therapy must be used with caution at these people, and patients with severe depression and suicidal ideation or attempts must be referred promptly for specialized treatment. You can see here in 2025 training slide set of GOLD, pulmonary rehabilitation, self-management, and integrative care in COPD are important part of the treatment management. And we can have those COPD follow-up checklists, as you can see here. Psychiatric disorders are one of the check points that we need to do in our patients. So thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation form, please. Thank you very much for your kind attention.
This program was presented by Medscape Education Global.